Hello and welcome back to another exciting episode of MedSynapse interview series. I'm your host, Tetri Shah, and today we are diving into another crucial topic, which is hypertension in geriatric population. Managing high blood pressure in elderly patients is not always straightforward. It requires a nuanced approach that considers priority, comorbidities, and evolving treatment goals. And to walk us through this complex yet critical topic, we are joined by Dr. Ketan Mehta, a renowned consultant physician, cardiopulmonologist, and diabetologist from Mumbai. With over 2 decades of experience and affiliations with leading hospitals like Asian Institute and Nanavati Hospital, Dr. Mehta is known for his patient-focused, evidence-based approach to chronic disease management. And Dr. Ketan is here to share his insights through a focused presentation that blends clinical experience with evidence-based guidance. So, Doctor, it is such a pleasure to have you with us, and the stage is all yours.
Thank you, Hatwi. At the onset, would like to thank MedSynapse for inviting me over here. So, friends, hypertension in geriatrics. We know you all have been managing hypertension, but in geriatrics, it is bit different, and we are going to see how it is different. So, we will cover up the introduction, epidemiology, diagnosis and classification, certain pathogenesis, and organ effects of hypertension, and the management aspects also. Okay, so introduction wise, we know the elderly are the most rapidly growing population in the world, and the data which has been collected over 30-year period have demonstrated the increasing prevalence of hypertension with age. So as the age advances, hypertension prevalence goes on increasing, and of course the risk of coronary artery disease, stroke, congestive heart disease, atrial fibrillation, CKD, and dementia is also increased in this subgroup of hypertensive. So the moment he has been diagnosed hypertensive, his risk of all these conditions goes on increasing in elderly population. Now, hypertension in a geriatric population, especially the management dilemma, is not only to the family physician but also to a cardiologist and a physician also. And the wide adoption of multiple drug strategies, because there are so many drugs which are available. So targeting the subgroup of hypertensive patients in specific risk conditions to lower BP beyond traditional goals, and sometimes difficult questions arise about how aggressive we need to be treating this elderly population. So what are the common questions which needs to be addressed? Is first, is hypertension in the elderly an emergency state or not? Second, does the BP control lower the risk associated with CVD and death in geriatric population? And third, what are the general principles of hypertension management in this specific population? Now let's look at epidemiology. So the very popular Framingham Heart Study has shown that in men and women free of hypertension at 55 years of age indicate the remaining lifetime risk for development of hypertension through 80 years are 93% and 91% respectively. That means somebody who is not having high BP at 55 years, till they become 80, 9 out of 10 will become hypertensive. So more than 90% of individuals who are free of hypertension at 55 years of age will develop it during their remaining lifespan. So that is the huge number we are looking at. So hypertension prevalence is less in women than in men until the 45 years of age, and is similar in both sexes from 45 to 64, and is much higher. So the trend reverses in after the age of 65 years. And the severity of hypertension, of course, increases with advancing age. Now in old people, SBP or systolic blood pressure is prognostically much more important than diastolic BP. And that's how, in geriatric population, you are specifically looking at control of systolic blood pressure. And there is an entity, isolated systolic hypertension or ISH, is the predominant hypertension phenotype, particularly above 70 years of age. I'm sure you all must be seeing this subset of patient population. So 70 plus with hypertensive, it is predominantly systolic hypertension. Now let's look at diagnosis and classification of hypertension. So one single reading of high BP does not label anybody as a hypertensive. So it should be based on at least 3 different BP measurements taken on more than 2 separate office visits. That is very important. And we know the majority of cases are due to essential hypertension, but it is important to identify certain correctable causes of hypertension, what we know as secondary hypertension. Now, there are various causes of hypertension in the elderly. So primary hypertension, of course, you have risk factors like obesity, black race, genetics, that is family history, physical inactivity, high sodium or alcohol intake, type A personality, and reduced nephron number. But secondary hypertension, which can result because of either primary renal disease, primary hyperaldosteronism, pheochromocytoma, obstructive sleep apnea, again a very important condition, Cushing's disease, coarctation of aorta, and certain drugs. And of course, you know there are various drugs like NSAIDs, nasal decongestant, erythropoietin, steroids, cyclosporine, stimulants like amphetamine, antidepressants like tricycline, and SSRI. So this also can cause hypertension. Now, this few terminologies and their meaning you should be well versed in, which are the common types of hypertension in elderly. What is isolated systolic hypertension? When SBP more than 140 and DBP less than 90. White coat hypertension, same as in the other population, high office BP and normal off BP, whereas mask hypertension is normal office BP and high home BP. Pseudo hypertension, SBP falsely elevated due to atherosclerosis, and postural hypertension, drop of more than 20 mm systolic or 10 mm diastolic within 3 minutes of static. Resistant hypertension, poor BP control on more than 3 agents including a diuretic. Nocturnal hypertension, BP does not drop by 10 to 20% at night, which ideally should be having. And nocturnal hypertension, BP drops more than 20% at night. So these are few terminologies you should be well versed. Now, history and physical examination can give clue to presence of an underlying disease, such as is there a renal failure, renovascular disease, hyperaldosteronism, pheochromocytoma, or Cushing's. And of course, there could be other suggestive factors like a lack of family history, unusual course, early complications, or resistance to therapy will make you think whether are we dealing with secondary cause of hypertension. Now, ISH or isolated systolic hypertension, it is one of the most common form of hypertension after 50 years of age, and it's present in most patients with hypertension who are more than 70 years. Again, more common in women and overweight. It is associated with a high risk of CV outcomes and mortality. And sometimes you need to be really looking into it because diagnosis may become difficult, especially when there is a high BP variability. Now, causes of resistant hypertension, you need to rule out the secondary causes and which we are aware about it. So there are false positive or pseudo resistance if there is an incorrect technique in measuring blood pressure, pseudo hypertension, lack of adherence to lifestyle, lack of patient's adherence to antihypertensive therapy, and suboptimal therapy. Now, hypertension in the elderly or geriatric population, what is the pathogenesis? So it's a multifactorial and it is complex. We know the vascular stiffness and increased arterial wall thickness which play a significant role, and that is how you also get the widening of pulse pressure, and there could be factors due to inflammatory or neurohumoral processes also. Now, aging is associated with naturally increase activity of renin, angiotensin, aldosterone system and sympathetic nervous system. It also is associated with reduced nitric oxide bioavailability, and that could be a progressive glomerulosclerosis. So you have a clear-cut multifactorial reasons. So now if I to describe certain characteristics of hypertension in the elderly, so what happens? There is an increased systolic blood pressure and pulse pressure, increased left ventricular mass and wall thickness, increased arterial stiffness, and increased calculated total peripheral resistance. And there are certain parameters which are decreased, that is cardiac output and heart rate decreases, renal blood flow decreases, plasma renin activity and angiotensin 2 levels decreases, arterial compliance and blood volume decreases, and diastolic blood pressure also decreases. So this is a pattern which is found in the elderly population. Now look at this arterial wall compliance and pulse pressure. Well, what happens if there is an elastic vessel? What will happen? Aorta will be more expansive, whereas in a stiff vessel the aorta will not be expansive, as a result of which there is a increase in flow pressures in arteriosclerotic artery compared to young artery, which will be C. Now this is the schematic representation of various BP profiles in older adults, and depending on the age group what has been found, that you need to look into the various pathophysiologic mechanisms which could be playing a plus minus additional role. So you need to really look into this. What is the basic likely pathophysiology, whether it is a peripheral resistance which we are looking at, or arterial stiffness which we are looking at, or there is a combination of both the entities which are there. Now let's look at end organ effects of hypertension in the elderly. So first look at cerebrovascular disease and dementia. So hypertension in elderly is a major risk factor for both ischemic stroke and cerebral hemorrhage. And ISH is an important component of BP related stroke risk. So always remember that ISH definitely carries an issue. Now there is a beautiful trial SHAPE, that is systolic hypertension in elderly program. So where it has shown the benefits of BP reduction for stroke risk, in which the active treatment had reduced incidence of both ischemic and hemorrhagic stroke. And there is a progress, that is progress trial perindoperitoneal protection against recurrent stroke study, that patients under antihypertensive therapy had fewer recurrent ischemic strokes compared to placebo. So obviously controlling the blood pressure, it has a significant benefit. In the systolic hypertension in Europe trial SYSTURE, which comprise of patients with isolated systolic hypertension, confirmed stroke prevention with BP control using nitrindipril with possible addition of enalapril, HCTZ or both. And in HIVET, that is hypertension in very elderly trial, patients in late elderly group were randomized to indapamide with an addition of perindopril if needed or placebo, and patients in indapamide group had a 30% risk reduction in fatal and non-fatal stroke. So what I want to highlight over here is that reducing the blood pressure definitely has an impact. So the prevalence of both hypertension and dementia increases with advancing age, and hypertension is an important risk factor for vascular dementia and Alzheimer's disease. So poor BP control is associated with an ever greater cognitive decline. The SCOPE study, the study of cognition and prognosis in elderly, compared candesartan versus placebo and found no differences in cognitive outcome between the two groups. But the HIVET COG trial found again non-significant 14% decrease in dementia with active treatment versus placebo. Now, let's look at coronary artery disease. So, elderly patients with hypertension have a higher prevalence of MI than elderly patients without hypertension, which is but obvious. So, the old dogma, lower the better, is not always true. This is what now you must understand. So there is a retrospective analysis of international verapamil Trandolapre study INVEST, which proved that the INVEST trial was designed to investigate two hypertension treatment strategies in patients with CAD. And this study included a large number of individuals, senior citizens more than 80 years old, and the secondary analysis was performed to assess the effects of strict BP control by reporting a J-shaped mortality curve with BP control. So which we have to be very careful. Now, talking about CKD, hypertension and aging both impact renal function, and elderly patients are more likely to have CKD, which we know where eGFR is less than 60, and SBP is a strong independent predictor of decline in kidney function among older patients with ISH. Now, hypertension and age-associated retinal changes. We know that retinal lesions prevalence increases with higher SBP, and persistent BP elevation produces intimal thickening, medial hyperplasia, and hyaline degeneration. So, hypertension is an important risk factor for retinal artery occlusion, and the final stages of retinal disease are caused by disruption of retina or blood barrier and lipid exudates in severely elevated blood pressure. Now let's look at the management part of hypertension in elderly patients. Now there are certain special considerations which we will have to give in management of hypertension in elderly. One is falls. We need to avoid falls in elderly population. Dementia, we need to target it. Frailty has to be looked into it. Systolic hypertension, we know that has to be the targeted point. Postural hypotension, we need to try and avoid it. Polypharmacy, again we try and avoid it. And care home residents, which is especially those who are not much ambulatory, we need to be taking care of. So what are the optimal target BP in older patients with hypertension? So determining the optimal target BP for older adults is a complex issue. BP target should be individualized based on each patient's unique health status and risk factors that you have to take into consideration. Benefits and risk of intensive BP control should be carefully weighed in the context of patient's overall health status and treatment goals. Decision to pursue intensive BP control should be made through shared decision making between patients and their healthcare providers. They should be well informed about it. So now let's look at office BP targets for drug treatment, and I would straight focus on senior citizen, that is patient 65 to 79 years old as per the European Society of Hypertension 2023. The primary goal is to lower BP to less than 140/80, that is class 1A recommendation. However, lowering BP below 130/80 can be considered if treatment is well tolerated, class 2B recommendation. Now, talking about the senior citizen with ISH, the primary goal to lower the SBP in the 140 to 150 millimeters of mercury range. So keep it in mind, you may not able to achieve less than 140 if it is ISH, and you may have to well accept between 140 to 150 millimeters of mercury. And what about patients who are more than 80 years old? Office SBP should be lowered to a SBP in the range of 140 to 150. So again, we do not aggressively target below 140. Even if it is between 140 to 150, we might have to accept it as per the ESH. Now, there are major clinical trials showing benefits of treating isolated systolic hypertension, and as per the SHAPE trial, CIST Euro trial, CIST China trial, all of them, whichever drug therapy it has used, it has shown beneficial effects also. Now, we must also remember non-pharmacological management. So, lifestyle modification is definitely recommended for each and every individual. Physical activity recommended are aerobic exercise, which is 90 to 150 minutes per week, along with dynamic resistance, again 90 to 150 minutes per week, or isometric resistance. 3 sessions in a week for 8 to 10 weeks of 4 into 2 minutes of hand grip, 1 minute rest, 30% to 40% of max voluntary contraction, which has to be kept in mind. What is the effect of regular exercise in BP control? Again, a beautiful publication which has shown effect of 30 minutes walk 3 days a week in an age group of 70 to 79. It has shown a significant difference which is there. Weight reduction, again a very important aspect. Dietary sodium restriction, physical activity, moderate alcohol consumption, and a diet such as DASH diet can be helpful. Potassium supplementation, calcium or magnesium supplements, consumption of probiotics, fiber, flaxseed, increased protein intake, consumption of garlic, dark chocolate, tea, coffee, and fish oil. All these are going to have a beneficial effect also. Now, pharmacologic management, when we talk about, so when lifestyle measures fail, obviously pharmacotherapy should be initiated. And the safety and efficacy of multiple medication has been studied for last 30 years. And there are RCTs which have consistently demonstrated that antihypertensive therapy in the elderly is effective in preventing total mortality, stroke, and coronary events. Now let's look at general principles of pharmacologic management. So we know there are several classes of antihypertensive drugs are available. The treatment decision should be guided by the presence of compelling indications such as diabetes mellitus, stroke, heart failure, and also by tolerability of individual drugs or drug combinations also. Now, as per the ESH 2023, in patients under well-tolerated treatment who reach 80 years of age, treatment should be continued as opposed to the myth earlier that at 80 years be lax. No, you be little lax, but treatment has to be continued. So age should no barrier to antihypertensive drug treatment at every age. The BP needs to be controlled. Now, there are Indian hypertension guidelines there, and I want you to focus on the older, that is senior citizen. What is recommendation? Step 1 is C or D, that is calcium channel blocker or diuretic, and especially with isolated systolic hypertension, this is the class of drugs recommended. Step 2, if not controlled, then either AC inhibitor or ARB or beta blocker plus calcium channel blocker or diuretic. So you don't combine C plus D, you combine either C or D with A or B, and then in step 3, C plus D plus either A or B, and then in a resistant hypertension you can add either alpha blocker or spironolactone or other diuretic. So we must understand the various classes, the main benefits and side effects in elderly population. So diuretics, of course, they are well tolerated, effective in systolic hypertension, reduces exacerbation of heart failure. But what is the side effect? Electrolyte imbalance, gout because of hyperuricemia and glucose intolerance, dehydration, and can worsen urinary incontinence. What about calcium channel blocker? Well tolerated, effective in systolic hypertension. It reduces stroke rates, but side effects are dizziness, bradycardia, peripheral edema, and constipation. What about AC inhibitor and ARB? Effective in patients with history of ischemic heart disease, heart failure, diabetes, and chronic disease. But side effects: chronic cough, hyperkalemia, acute kidney injury, angioedema. And remember, combining AC inhibitor and ARB can increase incidence of AKI or acute kidney injury, and hence should be strictly avoided. Beta blockers, they are benefits in patients with history of ischemic heart disease, heart failure, and atrial fibrillation. Side effects could be bradycardia, fatigue, depression, confusion. Of course, renin inhibitors are also effective. Side effects are hyperkalemia and AKI. Aldosterone antagonist, especially suitable in patients with heart failure, and hyperkalemia and gynecomastia could be the side effect. Centrally acting agents, alpha blockers, they are suitable especially with renal failure, but side effects like confusion, postural hypotension, dizziness, syncope, and dry mouth has to be kept in mind. So, now strategies are at patients. So, patient 65 to 79 years old. So, threshold for initiation of drug treatment is 140 to 90 millimeters of mercury, that is class 1A indication, and a primary goal less than 140/80. So this is the point which you should be keeping in mind. Patient 65 to 75 years old with ISH, again primary goal lower SBP in the 140 to 150 millimeters of mercury, and of course if the patient platelets can go down below also. Now, CCBs and thiazide or thiazide-like diuretics have been mainly used in the same population, class 1A recommendation, and initiation with a 2-drug combination is also recommended in most older patients with ISH, but that is class 1C recommendation. Now, for patients more than 80 years old, the threshold for initiation should be 160. Now, this is class 1B recommendation, and lower SBP can also be considered, but again level is 2C, and reduction of office systolic BP between 130 to 139 may be considered if well tolerated, is the level for class 2B recommendation which is there. Now there are certain additional recommendations are there. Initiation with monotherapy should be considered in patients with 80 and or advanced age. This is level of evidence 1C, and in patients with low office diastolic BP, that is below 70 millimeters mercury, SBP should be still lower. So you may come across somebody whose BP is 160/70. You are in a dilemma. You give a medicine. What will happen? So don't worry. Whichever is the higher BP, the drug will bring down that BP. Don't worry about a diastolic. So that is one point which you have to keep it in mind. Withdrawal of BP lowering drug treatment on the basis of age, even when patient is more than 80 years, is not recommended. This is the message again and again I would like to give. And treatment may start with overdose, and up titration should be slow. Again, depending on the case-to-case basis, we may have to take that call. Back titration or discontinuation of BP lowering drugs should be considered in patients with orthostatic hypertension. This, by all means, we have to avoid. And there should always be an assessment of functional and autonomy status, including cognitive function, which is very important. Now, this chart shows dosage of commonly used antihypertensive drugs. I'm sure all of you are well versed with, so I would not go into the details. So, calcium channel blockers, which are commonly used, are known dihydropyridines like diltiazem and verapamil, and dihydropyridines like amlodipine, felodipine, nifedipine, nitrendipine. The ARBs, you have got a benazepril, captopril, enalapril, fosinopril, lisinopril, perindopril, quinapril, ramipril, and grandolapril. Then ARVs, you have got azilsartan, pendisartan, you have got irbesartan, losartan, olmesartan, telmisartan, and valsartan. The diuretics, you have got a thiazide and thiazide-like diuretics. So, bendroflumethiazide, chlorthalidone, hydrochloroazide, indapamide. You have got a potassium-sparing diuretic like amiloride, eplerenone, spironolactone, triamdenic. And of course, you have a beta blockers which are also available like atenolol, bisoprolol, carvedilol, labetalol, metoprolol, nebivolol, propranolol. Alpha adrenergic blockers which are toxazocin, prazosin, terazosin. Direct vasodilator, so centrally acting drugs, you have got hydralazine, minoxidil, and central alpha agonist like clonidine, methylopa. Adrenergic depleters like rizapine, which was a good old time molecule but not into usage nowadays. So what are the recent advances in hypertension management? It is the telemedicine and remote monitoring. You have got a role with the precision medicine and digital health tools which are coming up also. And what are the future trends and research directions? So exploring the application of genomics, biomarkers, AI, and digital health solution in tailoring hypertension management for individualized care in geriatrics. Investigating the long-term effects of hypertension on aging, cognitive function, frailty, and mortality outcomes through large-scale cohort studies and interdisciplinary research collaborations. And anticipating the integration of wearable devices, telemonitoring systems, predictive analytics, and virtual care platforms in shaping the future of geriatric hypertension care delivery and outcomes. So, ladies and gentlemen, to conclude, hypertension is prevalent worldwide, and aging of the population means that there are more and more people with hypertension. Therefore, the scale of the problem of diagnosing, treating, and controlling hypertension is immense. Current efforts are channeled towards the detection and treatment of hypertension in middle and old age also. The linear rise in the prevalence of hypertension with age means that measures to prevent hypertension such as healthy diet and regular physical activity should start early in life. For those who have already developed hypertension, early diagnosis and treatment is important. Existing antihypertensive drugs are not ideal individually, and so a combination of drugs is needed in a large proportion of patients. The choice of such drugs should be rational and evidence-based. So these are the references which has been taken from American Journal of Hypertension, World Health Organization, and Journal of Geriatric Cardiology. So thank you so much for your patient hearing.
That was an incredibly valuable session, Doctor, on understanding and managing hypertension in the elderly. So thank you so much for sharing your valuable insights on this crucial topic and actually breaking down such a multifaceted topic with clarity and clinical depth. It was a pleasure having you with us today.
Yeah, my pleasure.
Thank you, Seth. And for our listeners, we hope this discussion helps you enhance your approach to geriatric care. And remember, if you're a healthcare professional who's eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platforms. MedSynapse platform is not just a resource. It's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until we meet again, keep learning and keep evolving.